So it's a real pleasure for me to ask Sanjay Popat to come up and give a talk on the management of atypical EGFR mutations. Basically, I've known Sanjay for many, many years now. He took over from me as the chair of the British Thoracic Oncology Group and also got very involved with the European Thoracic Oncology Platform and ESMO, and really has been stellar in his work in bringing those organizations forward. And I would say probably ETOP is probably the leading young thoracic oncology group in Europe now. So, Sanjay, please, looking forward to hearing your talk.
Thanks, colleagues, and hopefully you've had a bit of coffee to pick you up. You're C-maxing at this time, right? So the levels are good, right? So I've been asked to speak to you about atypical EGFR mutation. My disclosures haven't changed in the past 2 hours. You can see me at the back otherwise. Now, one thing I say to my fellows is the term EGFR positive is totally meaningless and should never be used. So if you learn nothing more from this presentation, learn that and delete it from your lexicon. And the reason is we have many different types of EGFR mutation. We have our classical EGFR mutations, and this is Daniel Tan's frequency pi, with the frequency of classical mutations in Asia on the outside, around 46%, and in the West, in the inside, 16.3%. And these are the classical common mutations, DEL19, L858R, and we can argue till the cows come home as to whether they should have Osimertinib monotherapy, FLAURA2, or MARIPOSA-1. We also have our EGFR exon 20 insertions. The frequency here is, broadly similar, maybe a little bit more in Asia, 2.9% versus 1.3% in the UK. And these affect codons 761 to 775 of the EGFR gene. And that's part of the C helix and something called the loop following the C helix. And these, as we've heard, are optimally treated with chemotherapy and amivantamab. And then we've got what I've been asked to speak to you today about, which is called uncommon, otherwise known as atypical EGFR mutations. And these are, as they say, uncommon, right? So they occur in about 1.6 to 2.2%, depending on whether you're in the West or East. And how they're defined depends on which series you're talking about. I sort of like to think about them as activating EGFR mutations or pathogenic oncogenic EGFR mutations which map to the kinase domain, i.e. exons 18 to 21, which are not L858R, and they're not DEL19 indels, and they're not exon 20 insertions. Everything else, basically. And the challenge that we have is that they're often compound. So we often see them uncommon and uncommon together, and sometimes we see them often classical and uncommon together. And this creates a level of complexity that we need to think about when we're thinking about how we're going to optimally drug them. So what sort of mutations have we got, and what frequency do we see? So this is a list of some of the atypical mutations and the diversity of mutations that we have. And I would suggest that we have our big friends in the top three, perhaps like England, Argentina, and Spain, perhaps. We have EGFR G719X, X because you cannot resolve the amino acid change because you've used a PCR technology, which could be G719A, C, or S. We've got L861Q and S768I. They're the big ones, right, that we see. They're the sort of common, uncommon. And then we've got the rarer ones thereafter. Now, if we look at the diversity of the top right-hand panel, you can see that these are often occurring compounds. So L858R tends to have much more compound mutations than DEL19. And similarly, if you look at G719, these mutations are much more frequently compound than L861Q. And there are biological reasons for that. L858R needs dimerization for oncogenesis, so it therefore has weaker oncogenic potential than DEL19. So it needs more drive, which is often why you find compound mutations more with L858R than DEL19. G719X by itself is not that strong kinase activity. So by itself, it's less likely to have oncogenic potential, which is often why you need another driver with it. And when we see these mutations together, if you're using long-read sequencing, which you're generally not in NGS, you tend to find that these are in cis, so they're occurring on the same DNA strand, driving that oncogenic potential moving forward. Now, we know quite a lot about the drug sensitivity of a variety of drugs that we've used over the years and these particular EGFR mutations. So this is one of my favorite papers by colleagues in Japan, published way back in the day in 2017, Science Translational Medicine, where a bunch of knock-in mutations were tested for sensitivity to first, second, and third generation EGFR inhibitors. And I've highlighted in red the DEL19s, and the L858R. And what you can see is that Osimertinib is mainly blue and Afatanib is mainly blue, meaning that both of those drugs can be used at pretty low concentrations to give you a lot of cell killing. So if we ignore the first generation drugs and really focus in on Afatanib and Osimertinib, and then we look at the uncommon mutations, so these occur in exon 18, the G719X mutations, and others, and you look at the exon 20 uncommon mutations like S768I and the exon 21 mutations, you can see that Afatanib has generally got better coverage. You get more cell kill at a lower concentration than you do with Osimertinib, right? So that's interesting. But, you know, these are all cell experiments, right? This is not human beings. And at the end of the day, we're not a cell in a Petri dish. We have to cope with the drug. So what does this mean for clinical practice? So the other thing to note is we've got another set of very good experiments done by colleagues at MD Anderson. This is Jacqueline Robichaud and Dr. Haymack and colleagues. And they have looked at the diversity of EGFR mutations with knock-in experiments and looked at the sensitivity of first, second, and third generation drugs. And essentially, they have classified all the mutations that we see into 4 main types. And I think this is a nice structural way of thinking about our mutations moving forward. They've defined our mutations as classical-like mutations, and that's the top right hand. And in that, we've got L858R and we've got DEL19. But we also have some uncommon mutations like L861Q. L861Q functions very similar to DEL19. It's uncommon, but actually structurally, and the way it binds third-generation drugs is very, very similar. So these mutations, like L861Q, do very well with third-generation drugs. Then you have T790M mutations. Then you have exon 20 mutations. Then you've got another group of ragbag of other uncommon mutations, which they have then called P-loop C-helix compressing, which they have called PAC mutations. These are mutations which result in a structural change within the kinase binding domain, which means that the second-generation drugs, like Afatanib, dacomitinib, bind better and give you better cell killing than third-generation drugs. So if you're reading your NGS report and you have no idea what you want to do, download this paper, look at the supplement, and it will give you your list of mutations and which drug you want to be using. So that's your cheats guide. I'll let you take a photo in the next 30 seconds. Right. Okay, so that's what you want to do in your molecular tumor board. So going back, so Afatanib sounds like it's great. So, but is it really great? Well, we have several data sets which have looked at this. This is in the top right-hand, in the top panel is the original pooled analysis of uncommon mutations, otherwise known as group 3 mutations, from the original Lux-Lung 2, which is the phase 2 trial, and the Lux-Lung 3 and 6, which is the phase 3 trials. You can see that there weren't many mutations that were picked up, and this is back in the day when actually we were letting any mutation into a EGFR mutant trial. How refreshing is that, right? And what you can see is that the response rate is really quite low, right? We're talking about 8.7%, and progression-free survival really very low, 2.7. Nevertheless, this has now got regulatory approval in the US at least for Afatanib for uncommon mutations. And a few years later, Dr. Muriel and I led a global retrospective analysis of what we were doing for these uncommon mutations, a study we led with Boehringer called Upswing. And if you look at the efficacy with Afatanib in the major uncommon mutations, otherwise known as G719X, for example, you're seeing response rates of around 50% with duration of response around 12 months. But when you see compound mutations, and when we're talking about compound mutations, we're talking about L858R together with G719X, DEL19 together with S768I, for example, that's bringing down the response rate from about 80% that you'd expect with L858R down to 50%. So the compound mutations, the rarer mutation drags down the response rate, drags down the duration of response as well. By the way, if you don't know what to do and you want to know the afatinib outcome, do log into uncommonegfrmutations.com, which is basically the web page for all of the individual patient outcomes for this data set. I often use it when I want to know what happens to a particular mutation, but it is entirely all to do with afatinib, and it won't tell you the efficacy for any other drug. Now, our Japanese colleagues have a sort of strange obsession with EGFR mutation, which are uncommon, which is fantastic for us because they do all the trials of this. And they've done a superb trial called Achilles or TOG 1834, in which they took patients with these atypical or uncommon mutations and randomized them to platinum doublet chemo, which I think is reasonable given the low response rate and duration of response, or afatinib, and investigators are allowed to choose 40 or 30 milligrams. In the bottom left-hand panel, you can see that the different types of mutations that were picked up were predominantly G719X, like I've said before, followed by L861Q, and then there were many that were compound, and there were a few classical compounds within that as well. The bottom line is that afatinib does actually pretty well, right? And the response rate, the progression-free survival you can see there is much better than chemotherapy, 10.6. Look, it's not the 18 months we're getting out of Osimono or 24 that we're getting out of intensified treatment, but it's certainly better than chemotherapy. And I think this really does justify afatinib as a potential standard of care for this group of patients. However, that's the data that they presented at ESMO 2023. And of course, being a nerd, I like to look at the actual data when it's published. And so when you look at the data when it's published, you see a little bit more granular detail. The bottom left-hand panel, you see the data on starting dose of 40, which is fantastic. But if you are choosing to start at 30, the data's not so good, and the progression-free survival benefit is therefore lost. So there is an element of drug intensity here, and dose intensity does matter. So you've got to get your afatinib in at 40 milligrams to have the benefit that we've identified. The other issue is that each of these different mutations structurally is very, very different. I've told you that L861Q behaves like a classical mutation, whereas G719X tends to behave more like a PAC mutation. So what about the response rate? Well, we're seeing some differences there. 719X is actually doing pretty well with afatinib, 66% response. L861Q, not so good, 46%, right? So maybe you need more of a classical treatment like osimertinib with L861Q than you need afatinib. But what's really interesting is S768I, which is a defined PAC mutation, should theoretically do better with afatinib. We only have N equals 3, and none of those N equals 3 responded. So I think, the question on S768I is still open. So you'll say, yeah, but I use osimertinib. Osimertinib works great for me, which is fair enough, right? So what data do we have on osimertinib? Well, we have loads and loads of data sets. By the way, if you're a resident and you haven't yet published your retrospective institutions data on osimertinib atypical mutations, please do, because everybody else has. And what we have here is 10 observational studies which have been published, together with 5 prospective trials. And this very nice meta-analysis of all of these has been published in JCO Precision Medicine. What it shows overall is a response rate with osimertinib is not bad. It's 51%, and the median progression-free survival is, again, not as brilliant as we would expect at 9.7 months. However, we do see some differences by mutation class. In the right-hand panel, we're seeing G719X response rate is not as high as you'd expect, right, because it's a PAC mutation, 32%. L861Q, classical mutation, you have a high response rate, 61%. S768I, a PAC mutation, but all of these studies are reporting response rates of around 60%. So maybe S768I is a PAC mutation, but actually osimertinib does a decent job in controlling it. But of course, the benefit of osimertinib that we have is not only the lower adverse event rate, which means you can get more of the drug in, so you can actually inhibit the drug because you bind better, you have overall better target exposure, but you also have an increased intracranial response rate. And in our patients with brain metastases, that is really very important as well. In this very nice paper, they also identify the outcomes in patients with non-PAC mutations, which are lower response rates that you can see there, 42%. With PAC mutations with osimertinib, we're getting 57% response rate as well. So this is an ongoing debate, right? Afatanib versus osimertinib, right? Which one do you use? And, Pepsi Cola, right? There is no head-to-head data of afatanib versus osimertinib. There is a diversity of mutations. We see uncommon mutations. We see compound mutations. We see PAC, non-PAC. Sometimes the CNS is involved. You want to drug the CNS better than you want to drug outside the CNS. You have fit patients, young, that can tolerate 40 of osimertinib, elderly patients. And many of these studies that we have got loads of other biases within them. So, personally, I think osimertinib is a very reasonable option for patients with uncommon mutations. And I personally individualize treatment decisions based on whether it's classical, PAC, do I need to get into the brain, do I not, can they cope with osimertinib 40 or not? That's just my personal view on it. Actually, is any of this relevant? I would suggest probably relevant now, but may not be for much longer. So there are many new drugs being developed, and I think the way we treat our uncommon mutations is going to change quite markedly over the course of the next 5 years. So our Korean colleagues have been using lazertinib, a Korean drug developed in Korea for quite a long period of time, and Dr. Park and colleagues have presented and now published data on the single-arm phase 2 data of atypical mutations with lazertinib, which we know functions very similarly to osimertinib, with a reasonable objective response rate of 50%, median progression-free survival of 10 months, right, giving us some confidence that we can use a third-generation drug under some circumstances. However, what I think is really very encouraging is cohort C of Chrysalis 2. So in this ongoing cohort expansion of combination AMI plus lazertinib, there was a small cohort of patients with uncommon mutations. N equals 49. These are not common by definition, but what we have is a response rate of 57%. You'll say to me, well, Popat, that's no difference to what we've seen with afatanib and osimertinib. Why do I need the toxicities of amivantamab? And I would point out that the median progression-free survival here is actually quite long at 19 months. Now, I know small numbers, that might come down, etc., but that does, it is a very nice median, and it does correlate to an overall survival that we had presented at ASCO by Dr. Neal of 41 months in this fit population that were in a phase 1 trial. So all those caveats as well. So I think this is a very, very nice cocktail to use for our patients with uncommon mutations. Unfortunately, it's not, as far as I know, being taken forward for registrational status. But I love our Japanese colleagues because they are doing a trial in this population where they are prospectively evaluating afatanib, which they have proven is a particular standard of care, versus AMI and LAZ in this West of Japan Oncology Group study called AGEHA. So I very much look forward to the outcomes of this in due course. The other thing that we need to recognize is we have multiple newer mutation-specific TKIs in development. We have enozertinib, otherwise known as ORIC-114, zipalertinib, furmonertinib, and silevertinib, otherwise known as BDTX-1535. This is a heat map of activity of each of the 4 drugs by mutation class. It's been developed by ORIC-114, so of course enozertinib looks the best in this. But it gives you a good idea of the diversity of mutations and some of the individual unique binding properties of each of these five different TKIs that we have and their potential inhibitory effect. Osimertinib, which is basically very, very similar to osimertinib, but it's got one amide group which is slightly polarized, which means you can get more of a drug in, which means you get better target exposure with lower toxicity, has published some data on uncommon mutations. This is back in World Lung at 2024. Small number of patients, very encouraging response rates in the relapse setting, very encouraging efficacy intracranially as well, and 240 which is intolerable with osimertinib, is tolerable with osimertinib. Although the grade 3 diarrhea is only 10%. And this is being taken forward in a prospective phase 3 trial, which may or may not be in Australia, I don't know, certainly is in the rest of Europe, cunningly called Alpaca, because it is enrolling PAC mutations only. So this is a very important study because it randomizes patients to osimertinib at 240, which is tolerable, 10% grade 3 diarrhea rate, which is lower than what we've seen with afatanib, right, 15%. And investigators' choice of osimertinib or afatanib. And it's really important, right, because this is the first time the FDA recognizes you can do a randomized phase 3 trial in uncommon mutations, right, which is important. It also means that the FDA has recognized that this biological classification of PAC exists, so it's now going to be within the legislative framework. And it also means that both afatinib and osimertinib are recognized as treatment options by the FDA. So let's enroll to this study and see whether Firmo makes it. Zipa is a slightly different compound, slightly different binding characteristics. This is being developed further in an ongoing phase 1 study with cohort D, which is patients with uncommon EGFR mutations. We have some data in relapse late-line patients with response rates of 21%. In a tiny number, 8 patients who are untreated, response rate was 62%. Global intracranial response was as high, 68% in patients with systemic responses. But we are having reasonable rates of diarrhea, 22%, but 0 grade 3 diarrhea. Okay, interesting, although there's a reasonable amount of paronychia. This drug is being taken forward in a randomized phase 3 setting in the adjuvant setting in patients with uncommon mutations. BDTX presented their data with silevertinib at ASCO just gone. They have classified this slightly differently. It's not just PAC mutations, but it lets in classical mutations, which are uncommon. So there's a few L861Qs in here as well. And we have very nice waterfall plots with very encouraging response rates. Median progression-free survival, 15 months, but quite a bit of diarrhea here, 19% grade 3 diarrhea. So a lot of patients needing to dose reduce to get the drug in. And finally, ORIC-114, otherwise known as enozertinib, has presented its dose optimization data at ESMO Asia last year. Hopefully we'll have an update this year. Diarrhea rate actually relatively similar to afatanib at 14%. We're seeing in this is a late relapsed population, response rates of 36%, very early data, and of course it's being taken forward. So I'll close by saying that EGFR mutations should really be classified into classical-like, T790M-like, exon 20-like, or PAC. Some atypical mutations are classical, some atypical mutations are PAC. Afatanib is typically recommended for PAC, but osimertinib definitely has activity. Amilaz has very good activity, but is not being taken forward as phase 3 as far as I know. We've got newer TKIs coming through, osimertinib, zipalertinib, enozertinib, different tox profiles, different CNS penetration, different mutation affinity. Bottom line is I never want to hear the term EGFR positive again. Thank you very much.
Any questions from the floor? Sorry, any questions from the floor? We have room for one or two, I think. Okay. Yes, here we go. Yes, Michael. Michael.
Thanks, Professor Popat, for those excellent talks. I wanted to ask about osimertinib in the adjuvant setting for these cancers. So I worked at Guy's, actually in London, for the last 4 years in the lung cancer unit, and the way that osimertinib is funded in the NHS is different to here. So it's sort of worded, I think, as being exon 19 deletion and LH58R as per the LAURA and ADAURA trials over there. Here, we're allowed to use it for anyone with a sensitizing activating EGFR mutation. So for patients who had, say, an L861Q in the adjuvant setting, would you be tempted to use osimertinib after surgery and potentially chemo? And then conversely, for those patients who have an exon 20 or one of those P-loop alpha-C helix compressing mutations, this is probably more relevant in the chemoradiotherapy space, but would you be using consolidation durvalumab for those where we wouldn't expect osimertinib to be effective?
Yeah, excellent questions. Thanks for that. So in the uncommon PAC or classical situation, the adjuvant setting, I mean, the data on ADAURA is only limited to L858 or on DEL19. So we have no data. The target trial, single-arm phase 2 trial, 5 years of osimertinib in classical mutations, cohort 1. Cohort 2, 5 years of adjuvant osimertinib in uncommon mutations, including L861Q and the PAC mutations as well. That trial has completed enrollment. Patients are on follow-up, and at some stage before I retire, hopefully I'll see some data. But on the basis of what we know, I think it's entirely reasonable to give those patients adjuvant osimertinib. I think you have a trial that's recruiting here. Tom, you were talking about that yesterday, and I would encourage you to recruit to that study, right, so you can generate some data. But if you're not going to be able to recruit to that study, biologically it makes absolute sense to do that, because we know that these patients have a poorer prognosis because of the relapse rate. The corollary question is in the stage 3 unresectable, right, whether you give these patients an EGFR kinase inhibitor, whether you give them durvalumab. Absolutely no point in giving them durvalumab. It's an EGFR mutation at the end of the day, so they behave very similarly, although there are some data to suggest that they have a slightly higher PD-L1 rate, they have a slightly higher TMB rate, slightly more inflamed tumor microenvironment. Having said all of that, I wouldn't give durvalumab to this group of patients. I would be very tempted to give them an EGFR kinase inhibitor if I could. I can't in London for reimbursement reasons, but if I had an L861Q who had inoperable stage 3, I would want to give them osimertinib thereafter off-label, recognizing we don't have any data in this situation. So another one where we need some prospective data collection.
Michael?
Yeah, thanks, Sanjay. Great talk. Given the benefit of chemo with osimertinib in sensitive mutations, it's surprising to me there isn't data on chemo plus osimertinib in these uncommon, because you would expect, if anything, the value of adding chemo would be even greater. But it didn't look that that was an arm in any of the randomized or proposed trials.
Yeah, and that's really mainly because, I mean, it's not an arm in any of the previous studies because commercially it's not been an important question to answer. So that's a commercial issue, right? From the academic viewpoint, I think this is an academic interesting point. And the role of chemotherapy together with TKI, I think, is very important. We don't have any data on osimertinib plus chemotherapy in uncommon mutations. I'd love to generate that sort of data. We do know that afatanib together with chemotherapy is not really tolerable. A lot of toxicities with that. So that's probably not going to be the way forward. We do know that some of these trials, like zipalertinib, for example, is looking at the combination of chemotherapy together with zipalertinib in the frontline setting, but in the exon 20 group of patients. Now, we don't have data that's going to report on that in the uncommon mutations, which is, I think, a bit of a shame. But I totally agree with you. I think what we've learned from the common mutation group, we should be able to translate. So if we could do something, we should do that. But I would personally generate the efforts on the newer drugs, because I think the newer drugs are probably going to take over this space rather than osimertinib or afatinib. So I wouldn't waste 5 years of my life doing something which is not going to be applicable when these new drugs then get approved.
Okay,
thanks.
I think we've actually reached time now, so thank you very much, Sanjay, for an excellent presentation. And anybody has questions afterwards, I'm sure Sanjay will be happy to answer them for you. Okay.